Hello, and welcome back to part 2 of our Cardiovascular Health Watch mini-series as we prepare for the Cardiovascular Symposium slated to take place on Saturday, February 16th. I'm your host, Marketing and Communications Manager, Natasha Letzum. Returning with us is Dr. Chichester to continue our conversation on cardiovascular disease and what you can do to reduce your vulnerability. Welcome back, Dr. Chichester.
Thank you.
For the benefit of those who may be just joining in, give us a brief overview about what we have spoken about thus far.
Okay, so our last chat, we began the conversation about cardiovascular disease as it relates to a heart attack and heart failure. The key points of that was that there's a distinction between the two. That heart attack really refers to just the damage to the muscle of the heart, and heart failure, though it is in part related to, just encompasses the heart's inability to meet the demands of the body. We spoke about the risk factors for both, which included mainly obesity, physical inactivity, uncontrolled hypertension, uncontrolled diabetes, and we spoke about cigarette smoking as a significant and independent risk factor for this. One thing I wanted to mention before we move on to the other topics was that heart attacks, we spoke about early presentation or seeking medical attention, because we can make a difference, especially if you present within the first 6 hours of a heart attack. There are interventions that can be offered that can actually salvage the injury to the muscle of the heart.
No, thank you for that. And right now we want to move along to speak about stroke. So what should we know about strokes?
Right. So the same underlying process for a lot of the cardiovascular disease is, as I mentioned, I think in the first part that we did, atherosclerosis. The blood vessels get furrowed up with a lot of debris, including cholesterol, and it does impact on blood flow. And it's even more relevant in terms of blood flow in the brain because the blood vessels are a lot tinier. So the capacity that the vessels of the heart and other blood vessels, other parts of the body, can be a little different. So just minor impedance to blood flow in the blood vessels of the brain can result in significant sequelae such as a stroke. Stroke is like a brain attack, essentially. There's no blood flow to that portion of the brain and the cells die. And the unique thing about the brain is that the cells don't regenerate. Similar to a heart attack, though, there are interventions that can be offered if patients present within a timely manner, except that it's a little less time you have with a stroke for that intervention than with a heart attack. Heart attack, we had said about 6 hours, but in the brain, it just doesn't handle lack of oxygen and nutrients as well. And so the timeline is usually about 2 to 3 hours. Wow. So you really are talking about the minute you start to have symptoms, you need to be at the hospital within 10 minutes, 15 minutes the most, to really be able to benefit from the same type of clot busting drug we spoke about in our first part series. So the strokes can potentially, result in significant consequences for patients, but we can intervene and make a difference for a lot of these patients. And, I'm speaking about stroke and, what causes it, but I haven't mentioned, what are some of the symptoms that patients have, so that, the public is aware of what to look out for.
Definitely.
So there's sort of a few key things. Changes in your speech. Persons tend to start to, very short space of time, notice that their speech is a little slurred. Or for some persons, if it's significant enough, they just cannot get out the words. They know what they want to say, but they just cannot get out the words. Or relatives may report things like they're speaking, but it doesn't seem appropriate. And they seem to be able to speak, but they just can't understand you very well. Okay. The other key thing to look out for is weakness. You may have one side of the body. It may be just the arm, it may be just the leg, or it may be both. That is weak, or that you feel heavy or numb on one side of the body. That's another key thing to look out for. In addition to that, persons may notice speech may be fine, may not be having limb weakness, but their face, it just looks a little droopy, it just doesn't look symmetrical. And oftentimes the patients don't report that. It's a relative or a close friend or family member that just notices, wait, something's not quite right. And based on just those, if you present early enough, persons are able to be diagnosed with a stroke and interventions offered very quickly to make a difference.
Mm-hmm. So Dr. Chichester, you spoke a bit about the interventions that can be made at the hospital to sustain life in a patient that's having a stroke or has had a stroke. Is there anything that can be done at home to prolong the life of that individual? Because as you said, time is of the essence.
Okay. So that's actually a good question. And I've been asked by patients that, and aspirin is one of the things that has been brought up as to whether it is important in stroke management, especially pre-hospitalization stroke management. And the answer is that it could be. And I'll clarify. Now, in a heart attack, usually it is recommended. There's no objections to the use of aspirin prior to the presentation to the hospital. But stroke is a little different because it depends on the type of stroke. And it is hard for a patient to know the difference because there's strokes as a result of a clot formation in the vessel and there's not enough blood flow. Mm-hmm. And in that case, certainly aspirin would make a huge difference because obviously aspirin is a little blood thinner. However, there is another type of stroke, as we refer to it as a bleeding type or a hemorrhagic stroke, and that's related to the fact that your blood pressures are significantly elevated and it breaches the integrity of the vessel. And so you can have a rupture of that vessel, and once the vessel ruptures, you're not able to get flow along that along the vessel to the cells that need the oxygen. But you present the same way. The same speech issues, the facial asymmetry, the weakness on one side of the body. So in patients with a stroke presentation, we usually say try to get to the hospital if it is that the doctors can determine with a brain scan, because that's what we do. Brain scan, whether it's a bleeding type of stroke or the other type, then aspirin can be given as well. But because of the risk of bleeding, and then the use of aspirin in somebody that's already bleeding, that can potentially make things worse. So aspirin is actually more relevant for a patient with a heart attack and using it as soon as possible, but not so much in a patient with a stroke just because of the potential for exacerbation of bleeding in a bleeding type of stroke.
Good information to know. So how do strokes affect the victim?
Okay. Well, and I should say not just the patient or the victim, as you put it, but the members of their family. Because based on some of the symptoms I've said to you, it results in a lot of neurological sequelae. Patients have difficulty in terms of just simply walking, using their limbs, using their hands, using their feet. And even if they're able to get to a point where sometimes they can move around and do a little bit more, sometimes it affects their ability to return to their original place of work or employment and do the kinds of jobs that they did before. So that has significant impacts on their living and in terms of their earning, their finances for their family. So it has that sort of sequelae, and associated there's a significant psychological component to it. So not just the physical ailment and the physical disability, but a significant psychological disability associated with, someone moving from being very independent, functional, to sometimes being completely bedridden and dependent on care. That takes a lot of adjustment, and not everyone is able to handle that.
So can persons ever regain full functioning of their muscles after a stroke?
So they can, not necessarily everyone, but they can. But some of the things that can sort of augur well for someone recovering function is early interventions in terms of rehabilitation, physical therapy, occupational therapy. The early and more aggressive we are with that, it does result in significant improvements and less sequelae of residual deficits. But you'll find that the persons who benefit more from that are the younger persons presenting with stroke. Find that the elderly persons, they don't handle as well the damage to the brain. There's not a whole lot of recovery. We find that younger persons, though there's damage, I did say before that there's not a whole lot of regeneration, but what we can have in especially younger persons is that other parts of the brain assume the role of the parts of the brain that might have been affected. So it's a lot of like delegation of tasks now, but that seems to happen a lot better in younger persons who present with a stroke. That being said, even the elderly person, especially a functional elderly person, early rehabilitation and of course sort of risk factor modifications do go a long way in terms of optimizing their recovery.
And what about the quality of their life? You spoke a little bit about how it affects the old and the young, and you talk about doing the therapy and rehabilitation. But for maybe those who may not have had that early intervention and have to live with some of these sustained effects, how can they improve their quality of life?
Okay. Well, part of the rehabilitation includes occupational therapy. Occupational therapy can be put in place. I mean, ideally would like it as early as possible, but even a little later down the line in terms of providing devices, sort of mobility assisting devices for patients who may, not be able to walk without assistance. So walkers, walker frames for patients can assist in getting them independent and moving again. There are other things like speech therapy that can be instituted, even if it's not initially long-term. Essentially helps to retrain the brain as to how to articulate, how to get out words, vocal training, those kinds of things are certainly available for persons. And of course, sort of psychological counseling, because a lot of these patients, as I said, there's a psychological aspect to it, and it limits sometimes their motivation to partake and be part of the rehabilitation services that are available. So sort of psychological counseling, not just for the patient, but for the family and the caregivers, that can make a difference long term. So though I mentioned that you want early intervention for these, I would still encourage patients out there to still seek out those rehabilitative services, because you can potentially still garner benefits even if it's later on. Because there's a lot that they can offer that I myself am not even able to expound on fully, but I've seen it reflected in a lot of my patients in terms of how well they've done even 3-6 months after a stroke, just by accessing these services.
Awesome. And are these services offered here at VVI HSA, and how can persons access them?
Okay, so it's offered both at VVI HSA as well as in the private sector. I do know that certainly as inpatients, our BVI HSA service does take care of your inpatient services. I know they have started trying to offer that to the community as well. But I know they're not able to handle the volumes that would come through. So I know that the private sector has been heavily involved in servicing the community from a rehabilitation point of view. We're talking about physiotherapy, occupational therapy, speech therapy. So it's both accessible in the out and inpatient, and I do know that our national health insurance covers both the services, both in and outpatient.
Awesome. Now, one final topic I want to touch on before we bring this program to a close is renal failure. What do we know? We know this is a hot topic here locally. Yes. We have quite a number of people on dialysis, and you know, renal failure is a problem here in the Caribbean. Talk a little bit about what we need to know about kidney failure.
Okay. Kidney failure is related to cardiovascular disease in that it can result, it can be a sequelae of cardiovascular disease, as well as it can be a precursor for the development of cardiovascular disease. Any compromise to the blood flow to a vital organ, such as the kidney, can result in injury to the kidney. In addition to that, kidney failure of itself, even if it was unrelated to cardiovascular disease, does result in hypertension, can result in significant compromise of the heart function, because oftentimes these patients end up with anemia and a low blood count, that's what I mean, and that can put a strain on the heart of itself, and flow through the vessels that supply the heart. So, you know, as I said, those patients can develop cardiovascular disease. But what I do want to really say about renal failure is that it is entirely preventable. Just like many of the cardiovascular diseases, the other cardiovascular diseases, one of the things, it's preventable, and yet still we're seeing, you know, an enormous burden to our healthcare system as a result of renal failure. You pointed out we have quite a number of patients on dialysis, reaching in the realm of close to 60, and frighteningly enough, our capacity presently in our dialysis unit would be to handle 60 patients. You know, and at the moment, I know they're working on ways of trying to expand that. But I think what we really should be working on, and I know, you know, BVI HSA has started to hit programs in terms of primary prevention out there, because, you know, whether or not we can expand the unit by, you know, capacity for an additional 10 or 20, you know, if we don't fix the underlying issues, then, you know, it's just going to continue to be an exponential number of patients with kidney disease. I think we've spoken about it in probably previous series that we've done. Oftentimes, patients with kidney failure don't have symptoms initially until they are close to end stage kidney disease and are on the brink of dialysis. And so it can't be emphasized enough how important it is to follow up with your physician, especially if you have risk factors for the cardiovascular diseases that we've spoken about, to seek out your physician so that your kidney functions can be monitored. Because if it is that we're able to catch, you know, dysfunction of the kidney in the very early stages, there's a lot that can be done to prevent the progression of. However, when it's later on, you know, stage 4, stage 5, and there are 5 stages. Stage 3, stage 4. It's not. I mean, we can try to reduce the tempo of which the disease progresses, but oftentimes dialysis becomes imminent. So it's incumbent on us to try to catch it stage 1, stage 2. The only way we're going to be able to do that is a lot of, you know, patients seeking out medical care, irrespective of whether they're feeling unwell or not. Part of the whole primary prevention strategy is getting into the culture of regular follow-up with physicians. And that's where we kind of need to start with kidney failure. But, you know, kidney failure is too prevalent in the BVI.
Definitely. And just from observation, I think I've been noticing that persons who are on dialysis, you know, their skin gets
There's a lot
darker.
of changes,
And, you know, what's going on there?
Okay, so it's a lot of changes. It's to do in part with the kidneys, but oftentimes it's also to do with the risk factors that probably would have resulted in the kidney failure. But agreed, once they've developed a certain stage of kidney disease, tends to be a very dusky scaling of the skin, dryness of the skin. They become hyperpigmented, meaning that they become very dark. It just tends to go with the toxins of the body building up and not being cleared by the kidneys very well. I know I'm sure it has a stigmata associated with it for a lot of those patients. And so general public needs to be aware of those things. You know, it's not even just about, oh, well, I have to start dialysis, but it's, you know, all these other things that go along with it that stigmatizes those patients.
No, I'm not sure if this is fact or fiction, but I've heard that, you know, drinking water is vital to kidney health.
Okay.
Is that true? Can you speak about that?
Okay. So drinking water in general, it's important for our health in general, not just kidney health. Our body is made up of 70% water. Keeping ourselves hydrated has benefits beyond just health of our organs, but in terms of our skin and our physical vitality and those things, it's part of that. But in respect to the kidneys, which is a question you asked, initially, definitely. Once you're hydrated, there is adequate perfusion to your kidneys. So in that regard, it helps. When one is dehydrated and there's not enough perfusion, it can impact on the kidneys. But when we're already in the throes of kidney disease and there's structural issues, you know, no amount of hydration is going to make a difference in terms of recovery of those functions. So I don't want us to go with a thought that, you know, once we've developed kidney disease, we can hydrate our way out of it. Hydration and stuff is just general health. And so though we recommend it, understand that is not necessarily going to undo damage that's already happened to the kidneys.
Now moving forward towards a healthier Virgin Islands, right? How can persons avoid kidney failure?
Seek medical attention early. Know your numbers. And I say know your numbers, and if you are hypertensive, if you are diabetic, you need to know what normal blood pressure should be, normal blood sugar should be, and not only knowing it, but monitoring. A lot of monitoring both at your physician as well as home, knowing what your number really is, because just like kidney disease, hypertension, diabetes, sometimes you don't have symptoms until it's too late. And not only knowing your numbers, but being an advocate for yourself, so that when you go to see your physician, you would expect that, you know, there are certain things done for you and reported back to you. Because sometimes there are patients out there, they would do blood tests and, you know, they take it for granted that, I guess it was fine, no one told you anything about it. But no, you have to be your own advocate. You have to know what is normal. Unfortunately, you have to, we're in the age where you just have to be an informed patient, and you demand a certain level of care for yourself. And I can assure you that the doctors will have to step up to that. So I think a big part of it is seeking health care, knowing why you're seeking health care and what you expect from health care. And of course, once you're informed, you should feel that there's an obligation to use your knowledge for your benefits. So it's not just a matter of knowing, but it's a matter of being able to follow all the healthy things that we should be doing, physical activity, in terms of dietary restrictions, in terms of avoiding things like heavy alcohol intake, cigarette smoking, those things. So become an informed patient and enforce the things that you do learn.
Thank you very much.
Okay.
Dr. Chichester, we appreciate you for coming on the program today and sharing this information with us. Let me remind you that this is part 2 of a 3-part mini-series educating the public about cardiovascular disease in advance of the Cardiovascular Symposium scheduled to take place on Saturday, February 16th in the lobby of the New People's Hospital. Join us next time for part 3 of our series, where we'll be speaking with Dr. Roger Miller to learn more about the symposium, its importance, and associated activities. Reporting for the BVI Health Services Authority, I am Marketing and Communications Manager Natasha Letzum. Thank you for tuning in.